Good morning. Today we are going to discuss Unit 3 and 4, that is Generalized Anxiety Disorder and Obsessive Compulsive Disorder, and Unit 4 is Mood Disorders. So we will be discussing about the treatment of GAD, OCD, and mood disorder also. So let us see what is generalized anxiety disorders. So we have already discussed about the other anxiety disorders like panic disorders, phobia, social phobia, specific phobias. So today we are going to discuss about generalized anxiety disorder. So it is a state of chronic, excessive, unreasonable worry about multiple life events or activities. Anxiety is not anchored to a specific object or situation, as we have seen in specific phobia, earlier described as free-floating anxiety. Individual is persistently anxious, often about minor things, and worry chronically. People with GAD spend a great deal of time worrying about a wide range of topics and describe their worrying as uncontrollable. So DSM-5 have some criteria on which you can diagnose the person on anxiety, generalized anxiety disorder. The criteria A is excessive anxiety and worry occurring more days than not for a period of at least 6 months about a number of events or activities such as work or school performance. So across the situation. B. The person finds it difficult to control the worry. C. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms present for more days than not for the past 6 months. Restlessness, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbance. Sleep disturbances could be of 3 types, like it's like getting difficulty in falling asleep. Then in between the sleep, there is a difficulty in getting proper sleep or getting up from the sleep, and in getting up early in the morning. So it's called initial insomnia, terminal insomnia, and intermittent insomnia. The focus of the anxiety and worry is not confined to features of an axis 1 disorder. Like all psychiatric disorders are classified as axis 1 disorder, panic attacks, phobia, OCD, PTSD, or psychotic disorders. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So this anxiety actually causing lots of problem in day-to-day functioning. So it lead to some impairment, some disability in the person. If the disturbances is not due to the direct physiological effect of a substance or a general medical condition or a psychiatric disorder. So the anxiety is not due to, like when you take certain substances, cocaine or opiates, alcohol, there may be some amount of anxiety, or the hangover may cause some amount of anxiety. So this anxiety is not due to any substance or any other medical condition like hypertension, cardiac problem, or any psychiatric disorder. So anxiety disorder is basically associated with functional impairment and increased risk of adverse health outcomes, including cardiovascular disease and suicide. Other psychiatric conditions like depression, panic disorder, post-traumatic stress disorder, and social phobia. So all these things may be present in generalized anxiety disorder. The person who is suffering from GAD may have other types of physical and psychiatric illnesses. Let us see the course of the generalized anxiety disorder. It is a chronic disorder. Chronic means it's not like for a few months you are having anxiety, then you are all right. No. In generalized anxiety disorder, it's basically going for many years. Though it tends to disappear after age 50 or for many people, it is usually replaced by somatic symptoms disorders with physical health concerns. Most of the people with GAD manage their lives though with some role impairment. People with GAD are less likely to avail the psychological treatment facilities because they usually visit physicians with physical complaints like muscle ache, gastrointestinal problems rather than for their anxiety. So this shows that the problem is chronic and having so many symptoms, having disability. Sometimes people quit the job due to their anxiety, and it's very difficult for a person to pursue or continue the job which the person was doing or study. Let us see the causes of generalized anxiety disorder. So there are certain biological causes, as we have discussed in our earlier classes also. Genetic factors. So genetic factors play a very important role in almost all psychological disorders. There is a mixed evidence for genetic factors in GAD. Strong evidence has been found for a common underlying genetic predisposition for GAD and major depressive disorder. A basic personality trait called neuroticism has been conceptualized as the common underlying predisposition for developing GAD and MDD. When CRH is activated by stress or perceived threat, it stimulates the pituitary gland, which in turn releases the adrenocorticotropic hormone (ACTH). We call it. The ACTH stimulates the adrenal gland, which in turn releases the stress hormone called cortisol. Neurochemical and neurohormonal factors. Neurobiological model is based on the research conducted between 1950s and 70s on the operations of benzodiazepines used for the treatment of anxiety. In normal fear reactions, neural firing is thought to be responsible for anxiety. This firing stimulates GABA system, which inhibits this activity and reduces anxiety. GAD may result from some defect in GABA system so that anxiety is not brought under control. The benzodiazepines may reduce anxiety by enhancing the release of GABA. The corticotropin releasing hormone CRH is an anxiety producing hormone. So there might be possibility of hormonal imbalance, neurochemical or neurohormonal imbalance, or genetic factors which may be responsible for the anxiety disorder. Coming to the psychoanalytic perspective of understanding GAD. So GAD is the result of a constant unconscious struggle between id impulses and ego. So we all know that id impulses are aggressive and sexual in nature and struggle for expression. So whenever they get any time, any opportunity to express themselves, they try to come into consciousness. And when they try to come into consciousness, ego get threatened. So that will reflected in anxiety. Since the source of anxiety is unconscious, person does not know the reason for anxiety and as a result remains always anxious and apprehensive. Since anxiety is not displayed onto a specific object or situation, hence the person is anxious nearly all the time. So the person is not aware but may remain anxious for all day. See the behavioral and cognitive perspective. So, according to behavioral perspectives, the facilitators of anxiety may be environmental factors, for example, other people or social situation. A person who spends most hours on his or her day with other people may be anxious because of the people or the social situation and not because of any internal factors. So this is the interpretation of the behavior. According to cognitive behavior perspective, GAD results from distorted cognitive processes. Like there is a tendency to misinterpret the threat or to exaggerate the threat. So the threat perception will be high in the persons who are having GAD. So the people with GAD often misperceive benign events such as crossing the street as involving threats, and their cognitions focus on anticipated future disasters. People suffering from GAD are more inclined to interpret ambiguous stimuli as threatening and to rate ominous event as more likely to occur them. So they always anticipate that something bad may happen. Okay. So coming to obsessive compulsive disorders. So let us see first what is obsession and what is compulsion. So OCD is characterized by occurrence of unwanted, intrusive, repeated thoughts, images, and impulses, which usually causes tension and accompanied by compulsive behavior. So there are three qualities. One is obsessions are unwanted; you do not want them. They are intrusive; they come again and again into your mind, repeated and repeatedly they come, and they could be come as a thought or images or impulses, and when they come there will be lots of tension or anxiety. So you have to reduce the tension and anxiety, and the shortcut of reducing the tension and anxiety is compulsive behavior or certain ritualistic behavior. So compulsive behaviors are carried out either to undo or neutralize obsessions or to prevent the occurrence of some dreadful event. Compulsions reduces the tension or anxiety. So there will be conditioning between obsession and compulsion. So whenever the obsession will be there, the compulsion definitely will be there. So the compulsions are of two types. One are mental compulsions, another one is uh, behavioral compulsions. So mental compulsions you cannot see. For example, if the patient is getting thought of death of his family member, so the person may not do behaviorally anything, but mentally the person may chant some certain mantras or remember the god or reciting certain slokas. So that is called internal compulsion. But when the person getting thought that hands are dirty, so person has to go and wash his hands again and again. So that is called overt compulsion. So overt compulsion and overt compulsion. Let us see the criteria given in DSM-5 for obsessive compulsive disorder. A. Presence of obsessions, compulsions, or both. There are certain illnesses in OCD where only obsessions are there, no compulsions, or just mental compulsions. So obsessions are defined by 1 and 2, like recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance, as intrusive and unwanted, and that is in most individuals cause marked anxiety or distress. So marked anxiety and distress, this is the I think core quality of obsession. But in chronic obsessions, there may not be anxiety or distress. So you can differentiate certain repetitive thoughts with obsessions, like when you chanting mantra for an hour, so they are repetitive, but they don't cause anxiety in you. So those are not called obsession. So the second one, the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, for that is by performing a compulsion. Neutralize means to like diffuse the effect of those thoughts, like the we diffuse the bomb. So after diffusing, there will be no effect of the bomb, negative effect. The same way, the patient they diffuse that they neutralize the thoughts, so there will not be any anxiety. So compulsions are defined by 1 and 2, like repetitive behaviors, for example, hand washing, ordering, checking, mental acts, for example, praying, counting, repeating words, or that the individual feels driven to perform in response to a obsession or according to rules that must be applied rigidly. So all the rules must be applied strictly. So this is the quality of compulsion. If something is left, the act should be repeated by the person. The behavior or mental acts are aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent or are clearly excessive. The criteria B is the obsession or compulsions are time consuming. So the first criteria is they should take at least 1 hour of per day. So you have to spend 1 hour in the thoughts or rituals you are doing due to obsession or compulsions. So then it may fulfill one criteria. So if the time taken by obsession or compulsion is less than 1 hour, generally it is not diagnosed. But it may be diagnosed depending on certain other variables. So the obsessive compulsive symptoms are not attributable to the physiological effects of a substance or another medical condition. The disturbances are not better explained by the symptoms of another mental disorders. So here you have to keep one thing in mind, like obsessions are common in certain other disorders also. For example, certain psychotic disorder, depression. So they may be comorbid, but you have to see if this is primary or secondary, and all the criteria must be fulfilled. Then you can diagnose both the disorders. For example, OCD and depression, or OCD and generalized anxiety disorder. So let us see the comorbidity with other disorders. Mood and anxiety disorders, for example, social phobia, panic disorder, generalized anxiety disorder, post-traumatic stress disorder, often co-occur with OCD. Major depression is about 20% individuals with OCD. Dependent and avoidant personality disorder is also seen with OCD, and body dysmorphic disorders is also reported by OCD patients. So body dysmorphic disorder means the person is preoccupied with one part of the body and it is causing too much distress in the person. For example, the person may be preoccupied with his nose and he wants it should be little short or small or something like that, and he is very much disturbed. And one of the body dysmorphic disorder is related to uh, teeth. The person may be preoccupied with the arrangement of the uh, teeth or the way they are there. So all these things may cause lots of distress in the person. So if comorbidity is there, the severity of OCD will be high, and it's basically become difficult to treat. Let us see the causes of OCD. So again, like genetic components is significantly stronger in the early onset of OCD than in the later onset of OCD. Also, tick-related OCD childhood, which is linked to Tourette syndrome, has also been found to have a significant genetic component. So, not only in OCD, in almost all psychiatric disorder, if the onset is early, like if it is during the childhood or early adolescent stage, so it basically reflects the genetic predisposition. Okay, but if later on someone has developed, for example, at the age of 20, 25, 30, so then the role of genetic components will be little less. And structural and functional abnormalities of brain. Brain imaging has shown abnormalities in cortical and subcortical regions such as the basal ganglia. There are so many MRI studies which has reflected this thing. PET scans have shown higher level of activities in orbitofrontal cortex and cingulate gyrus. In turn, all these structures are connected to the amygdala, thalamus, and the limbic system. Okay, so this circuitry system basically very prominently seen in OCD. Neurochemistry of brain. There is an involvement of serotonergic system in OCD. Selective serotonin reuptake inhibitors called SSRIs have also proved to be effective in treatment of OCD. So there are medicines uh, which are from the group of SSRIs are given to treatment to treat the OCD. Imbalance in serotonergic activities leads to OC symptoms. So that's why if you prescribe SSRI, like psychiatrists when they prescribe SSRI, so there will be reduction in the uh, frequency of the obsessions and intensity of the obsession. Psychological factors also explain the causes of OCD. Learning theory. So conditioning is there, but according to Maurer, he has given two process theory of avoidance learning. So basically, this Maurer's theory explains OCD very well. So it has two steps. So first step, like through classical conditioning, the neutral stimuli get associated with frightening thought or elicit anxiety. And then second step, a person tries to prevent infection by washing hands or clothes, which also reduces the fear of contamination. So what happens then in future? This behavior is likely to be repeated whenever the person feels anxious about contamination. Such behaviors reduce anxiety, hence these are extremely resistant to extinction. So let us see one example. A person gets a thought of contamination. So generally, like we go to washroom, then after coming from the washroom, we wash our hands. And once we have, suppose one person has gone to a public washroom, and there he saw something like the doorknob is contaminated. So he may feel little anxiety. So what he will do, he will wash his hands. So the washing the hands will reduce the anxiety. So it means whenever there is a anxiety, the person will wash hands. So this conditioning become more strong. That's why it's whatever you tell the person, your hands are not dirty. The person knows that his hands are not dirty, but still the person keep on washing his hands. Cognitive perspectives, the paradoxical effect of thought suppression. Like the more you suppress the thought, the more they will come. So attempts at suppressing of thoughts in normal people often leads to increase in those thoughts later. So degree of thought suppression is different in OCD. It leads to negative mood, cognitive biases, and cognitive distortion. So what happens when the person basically getting one thought, unwanted thoughts related to ill health of the child or the death of the family member. So the person tries to suppress. Why? Because the person, how can I think like this about my son or about my family members? I'm not a very good person. So the person tried to suppress the thought. So lots of energy is required in suppressing the thought. And the person may get exhausted. This may lead to negative mood. And even though the person trying very hard, the thoughts may come. After some time, the thought may again come. So the person may feel helpless, exhausted, negative mood. And all these things may lead to certain cognitive biases and cognitive distortions. And all these cognitive biases and distortions may again create lots of problem for the person. Coming to the evolutionary perspective, like OCD has a role in our survival. Why? Because it protects us from contamination, from any infections, any illnesses. So we keep ourselves clean and remain hygienic is good. So our thoughts about contamination and subsequent action to prevent it helps us to protect ourselves from potential infections. Displacement activity shown by many animals in stressful situations resemble compulsive actions of OCD. But remember this thing, like during the COVID time also, we used to wash our hands again and again. Every time we go out, we touch something, we wash our hands. It protected us from COVID. But remember, these are the ritualistic behavior, or we can say that these are the repeated behavior. For compulsion, it must reduce the anxiety, and for obsession, it should be again and again, and they create anxiety. So some of us might have some amount of obsessive thoughts about washing our hands at that time during the COVID time, but it was purposely done act by most of us. So not those who all were washing their hands again and again will be labeled as OCD or suffering from OCD. Okay, let us see the unit for mood disorders. Mood, we know it's our related to emotions, feelings. Okay, so let us see what are the different types of mood disorder. So first we let the difference between emotion, understand the emotion and mood. So short-lived affect with usually a known cause, like when someone scolds you, you may feel angry. Short-lived. Mood, longer-lasting emotions with no clear starting point. Like when you feel depressed, you may not remember when it started first time, which day, at what time. There in emotion there are diverse kinds of emotions such as joy, pride, anger, guilt, sadness, etc. But mood is classified as positive or negative. Triggers for emotion are more easier to identify, whereas it is difficult to identify exact triggers causing low mood or high mood. Expressions of emotions usually follow facial expressions. Expressions of mood have no unique mode. Generally, it is done in non-verbal form. So, a mood can again be in mental status examination. It can be divided into two, like mood when the person says about his or her mood, so we call it mood. But when we observe the patient, so we call it affect, how the person looks. So mood disorders primarily affect a person's emotional state. Affected emotional state may be experienced for longer duration. So for calling a mood, persistent mood as a mood disorder, it must be persistent for longer period of time. Just 1 or 2 days will not suffice the criteria. So we can divide the mood disorder into unipolar and bipolar mood disorders, and another category is also other specified or unspecified mood disorders. So under unipolar mood disorders, we can divide into four categories: mood, major depressive disorders, we call it MDD, dysthymia, and a depressive disorder due to another medical conditions seen in cardiac patients or cancer patients, and substance-induced depressive disorders. It is very commonly seen in alcoholics and those who are using opioids. They have mood disorder symptoms. Under bipolar mood disorders or bipolar affective disorders, there are various categories called bipolar 1 disorder, bipolar 2 disorder, or cyclothymic disorder, bipolar and related disorder due to another medical condition, and substance-induced bipolar disorders. So let us see these disorders into a little bit detail. So yeah, so under major depressive disorders, so this is basically clinical depression and the periods of extreme sadness, hopelessness, loneliness, or emptiness with a variety of physical, cognitive, and emotional symptoms. So these will be the basically clinical manifestation of the major depressive disorder, and they may be of shorter duration or long term. Uh, like shorter duration means not for a day or two, it may be at least for a 2 weeks or 3 weeks. So generally 2 months is considered as a adequate time for diagnosing a major depressive disorder. Dysthymia is a long-term form of depression. So the duration is at least 2 years. So if low mood persistent for at least 2 years, then we call it dysthymia. So what are the symptoms? So loss of interest in normal activities, hopelessness may be there, low self-esteem may be there, low energy, sleep changes, and poor concentration. It means the person may have depressive like of symptoms but with less intensity, and if they fulfill the criteria of major depressive disorders, then we call it double depression, like dysthymia with mild depressive disorder or moderate depressive disorder. So there might be possibility of having one or two depressive episodes, but it may not be there. Okay, so depressive disorder due to another medical condition. So prominent and persistent period of depressed mood or markedly diminished interest or pleasure is seen when the person is having a stroke, multiple sclerosis, Huntington disease, Parkinson disease, hypothyroidism, Cushing syndrome disease or syndrome, traumatic brain injury. So in female, the hypothyroidism is one of the major cause of low mood. So if someone, suppose a female, a 40 years of female is coming to you for complaints of low mood, not enjoying any activities, easily fatigability, not doing any work, do not feel like interacting with others, and it disturbed sleep. So you should not start CBT or any psychological intervention with the person. First, the lady should be seen by a physician or a psychiatrist. Okay, so all these things should be ruled out. There is no hormonal disturbances, there is no other disease. Then if it is clear, then you can see the patient depending upon the severity of the symptoms. So remember this thing, in most of the cases medicines are very much required. So if someone is on medication and coming to you showing improvement, so never say that you do not require medicine. You can be cured with counseling. No, whatever results are there, the researchers says that the best results seen when the medicine and psychotherapy given together. So never say this thing, you should stop medicine or reduce medicine. This is not the field of psychologist. The medicine is dealt by the psychiatrist. So we do not have any knowledge about such things, so we should not tell anything about this. Then the depression may be due to substance induced. So substance can cause depressive symptoms. Alcohol, cannabis, cocaine, they are very commonly associated with depressive symptoms. So onset occurs within the first few weeks or 1 month of use of the substance, and depressive symptoms usually resolve within days to weeks once the substance is discontinued. So if it is substance induced, then it may discontinue, but if it is persistent for longer period of time, like the person is taking substance for longer period of time, for 2 years, 3 years, 4 years, then there is a possibility that once the person discontinues the substance, there may not be automatically all depressive symptoms will go. So the person may need treatment for depression also. So there are 3 types of symptoms seen in depression: affective, physical, and cognitive. Affective means mood related, Physical means body related, and cognitive means thought related. So under affective depressive mood and anhedonia. Anhedonia is basically like inability to enjoy pleasurable activities. You are watching movie, you are watching your favorite serial, but you are not enjoying, you are just watching. Earlier you were enjoying, but after developing depression, you are not able to enjoy. So that is called anhedonia. Or anhedonia is also associated with the way you are seeing the world. Okay, nothing is enjoyable in this world. The world is full of pain, full of sorrow. So those type of things is also related to. Under physical, agitation or psychomotor retardation. Agitation means the person may become restless when the person is having depression, or in maximum cases in our country we see psychomotor retardation means the person's thought process is slow, the person's actions are slow. If you say the person to do some work, but the person may take lots of time. In walking, the person may take more time. Okay. So slowness you may notice. Insomnia or hypersomnia. Insomnia means sleep disturbances, lack of sleep, or loss of sleep, or disturbances in the sleep, whereas hypersomnia is getting more sleep. Like earlier you were sleeping for uh, 8 hours, now you are sleeping for 11 hours, 12 hours. Then significant unintentional weight loss or gain. In our country, most of our patients they lose weight and they do not gain. But in Western countries, persons in depression they gain more weight because they do not do much activity. They eat lots of things, so they put on lots of weight. Because in depression, maximum patients they report they do not feel like eating. So appetite, lack of appetite leads to weight loss, fatigue or loss of energy. So this is also a very core characteristics of depression. Like the person without doing any work, the person will feel tired. The person will not feel any energy to do any work. So under cognitive category, cognitive symptoms like the feelings of worthlessness, helplessness, hopelessness, and excessive guilt may be there. The person may think that he is not worth, uh, the world is not worth to live. There is no one to help him out, and his future is hopeless. And the person may have excessive guilt about the acts which he may not have done. The diminished ability to think or concentrate or indecisiveness. The person may not think properly as he was thinking earlier, and he may complain that he is not having concentration. This is basically like seen in the adolescents or the students, those who are appearing for exams or when they are in the 9th, 10th, 11th, 12th. So they repeat, they complain that they can't focus, they can't remember, they can't concentrate. So this could be one indication of the presence of depressive symptoms or development of the depressive symptoms. And the person may have recurrent thoughts of death wishes, or suicidal ideation. So generally, if there is any symptoms, either affective, physical, or cognitive, if there is a one symptom only, we must consult doctor if the symptom is persistent for longer period of time, for a month or two, then we must consult experts. Let us see the DSM-5 criteria for major depressive disorder. The individual must be experiencing 5 or more symptoms during the 2-week period, and at least one of the symptoms should be either a depressed mood or loss of interest or pleasure. Depressed mood most of the day, nearly every day. Markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. Significant weight loss when not dieting, or weight gain or decrease in increase or increase in appetite nearly every day. A slowing down of thought and a reduction of physical movement. A fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt nearly every day. Diminished ability to think or concentrate or indecisiveness nearly every day. Recurrent thoughts of death, recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. At least one of the symptoms is anhedonia or low mood. The symptoms cause clinically a significant distress or impairment in social, occupational, or other important areas of functioning. The episode is not attributable to the physiological effect of a substance or another medical condition, as we have seen in all other disorders also, and there has never been a manic episode. If there is a manic episode, then the diagnosis will be different. So, DSM-5 criteria for dysthymia or persistent depressive disorder. Depressed mood for most of the day, for more days than not, as indicated by either subjective account or observation by others, for at least 2 years. So remember this thing. If any type of depression which persisted for more than 2 years is termed as dysthymia. Uh, Presence while depressed or two or more of the following presence of these symptoms, like poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decision, feeling of hopelessness. During the 2 year period, the disturbances, the individual has never been without the symptom in criteria A and B for more than 2 months. These are the A and B criteria. The criteria for a major depressive disorder may be continuously present for 2 years. There has never been a manic episode or a hypomanic episode, and criteria have never been met for cyclothymic disorder, which we are going to discuss in subsequent slides. The disturbance is not better explained by any schizophrenia spectrum disorder or any other psychotic disorder. The symptoms are not attributable to the physiological effect of a substance or another medical condition. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Coming to the bipolar affective disorders. So, as we have seen, bipolar 1 disorder, bipolar 2, a cyclothymic disorder, bipolar and related disorder due to another medical condition, substance-induced bipolar disorders. So, bipolar 1 disorder. So, what are the general features? It is earlier it was called manic depressive psychosis. So often characterized by mania, period of abnormally elevated extreme changes in mood or emotions, energy level or activity level. Engagement in risky activities that may result in negative consequences for themselves or others. Individuals may also present with decreased sleep, grandiosity, talkativeness, racing thoughts, and indiscretion or risk-taking behavior. In mixed features, like in some cases, quick shifting of mood between mania, anger, irritability, and or depression. Females are more prone to experience rapid cycling and mixed features. However, the findings are contradictory. Cognitive deficits are similar to schizophrenia but less severe. If we see the comorbidity, the anxiety disorder is mostly present, personality disorder, substance use disorder, impulse control disorder, oppositional defiant disorder, conduct disorder, ADHD. Let us see the bipolar 2 disorder. So, general features are recurring mood episodes consisting of at least one major depressive episode and at least one hypomanic episode. So remember this, in bipolar 2 there won't be any episode of mania, there will be hypomania, the less intense mania called hypomania. The depressive episode must last at least 2 weeks. Hypomanic episode must last at least 4 days. Disability like prognosis, if you see the prognosis, how they can be easily treated. So disability is similar to bipolar 1. Economic burden is 4 times more than the bipolar 1, and because they do not seek treatment, many of them. Individuals with a rapid cycling pattern typically have a worse prognosis. Rates of successful suicide is 1 in 25 individual, which is similar to bipolar 1. Several episodes of depression before their onset of hypomanic episodes. If we see the comorbidity, almost 60% have some comorbidities like anxiety disorder, substance use disorders. Almost 40% have one lifetime eating disorders, anorexia nervosa, that is more common, and bulimia nervosa. Coming to cyclothymic disorders. General features are chronic fluctuating mood disturbances that consist of numerous hypomanic symptoms and depressive symptoms. Mild form of bipolar 2 disorders begins in adolescence or early adulthood. Onset is insidious. Insidious means slowly it develops. Persistent course, 15 to 50% chances of developing bipolar 1 and bipolar 2. If we see the comorbidity, like presence of other illness with cyclothymic disorder, 10 to 20% diagnosed with borderline personality disorders, substance use disorders, sleep disturbances. Children with ADHD are more likely to be diagnosed with cyclothymic disorder. Bipolar and related disorders due to another medical conditions. So general feature like bipolar disorders may be seen in medical conditions, other medical illnesses. So there is a prominent and persistent period of abnormally elevated, expansive or irritable mood and abnormally increased activity or energy. This is attributed to any physical or medical condition, and the presence of mania or hypomania in initial presentation of the medical condition within 1 month. Common medical conditions: Cushing's disease, multiple sclerosis, stroke, traumatic brain injury, or any other medical condition. In remission or in full recovery, symptoms generally disappear. So, what are the differential diagnoses? Like you have to differentiate the disorder with the other disorders like delirium, catatonia, acute anxiety, and medication-induced depressive or manic symptoms. Delirium means where the person is not aware about the surrounding. Generally, it could be due to brain disease, could be due to substance use. In catatonia, the person is not able to move the body parts, maintains a posture for very long period of time. Like it's not possible to stand at a place or sit in a position for more than 2 hours for a normal person, but the person maintains this position. Coming to substance-induced bipolar disorders, so general features are substance is attributed to manic or hypomanic and a depressive disorder, and occurs during the use of substance or withdrawal state. So, what are the chances of prognosis? In phencyclidine-induced mania, it presents with delirium first, then progression to mixed or manic states. Symptoms typically emerge within minutes or to an hour after ingestion. Then stimulant-induced mania, then medication-induced hypomania or mania, corticosteroids-induced mania or hypermania, or some immunosuppressants. So all these may lead to episodes may be brief, and what happens in most of the time when you stop taking the substance, the symptoms subsides. So hypomania, mania, or mixed or depressed state begins several days after the ingestion of certain substances, whereas it may immediately present after ingestion of the substance. So if you take the substances in higher dosage, it's more likely that the bipolar symptoms may be there. Coming to the last and interesting section of my presentation in today's class is how to treat generalized anxiety disorders, OCD, and mood disorders. So cognitive behavior therapy is the highly used therapy in treatment of any psychological disorders. So let us see in generalized anxiety disorders. So CBT uses a combination of behavioral techniques such as progressive muscles relaxation exercises to relieve the physiological symptoms such as breathlessness, muscle tension, and cognitive techniques such as cognitive restructuring for dealing with the psychological symptoms such as anxiety, cognitive distortions, catastrophizing, etc. Uh, Coming to treatment of OCD, so cognitive restructuring is required. One of the very highly used technique is called ERP, exposure therapy and response prevention. If the patient is having contamination, obsession, and compulsions, so ERP has been very effective. So what we do is, so therapist along with the client prepares a hierarchy of distressing stimuli which is rated by the client on a 0 to 100 scale in terms of the severity of distress or anxiety caused to the client, caused by this uh, thoughts. So then the client is asked to expose himself to stimuli given in a hierarchy in ascending order of the anxiety that causes anxiety tension such as touching the door or no. Here you have to remember that like once you prepare the hierarchy, you have to start with the moderately anxiety causing stimulus, not just the least causing. Otherwise, it will be just wasting of the time. And all these exercise has been done with the consent of the patient. And you have to explain that why you are doing this exercise, because your purpose is to habituate with the anxiety or tension. Because if you habituate it for some time, it will go by itself. So this is followed by response prevention, where the client is asked not to engage in any rituals, washing hands, to deal with the anxiety provoked by the obsession. Coming to treatment of mood disorders, so mainly pharmacological treatment and CBT. So in bipolar affective disorder is there are several medicines which psychiatrists prescribe to the person, and if the person becomes stable like hyperactivity or other psychotic symptoms are under control, then you can start cognitive behavior therapy with the patients. And remember this thing: you are not supposed to confront or argument with the patient, because if they are in manic state, they may hit you or they may get disturbed with your way of talking. So keep remember this thing: when all psychotic symptoms are subsided, then only is trained psychologist, they used to talk with such persons. In case of depression, there are different medicines also. They are given to the patient, and generally, clinical psychologists, they ask the patient to take the medicine as it was prescribed. So do not try to change the medicine. Do not lower the dose. Do not skip the dose. So basically, trained psychologists, they counsel the patient for the adherence, compliance for the treatment. They should be taking adequately for the dose. The way they are written, they are taking in the same manner. Another method of treatment is called electroconvulsive therapy (ECT). Nowadays, it is given in a modified form. That's why it is called modified ECT. Modified ECT is given with the anesthesia, so the person may not have very severe seizures, because when the electric current is passed, the person may have seizures. So in modified ECT, there is no risk of fracture of bone, or it is not painful at all. Under non-pharmacological approaches to depression, generally transcranial magnetic stimulus, which is called TMS, deep brain stimulation, and bright light therapy, they are also given, and biofeedback is also used. In mood disorder, psychotherapy, cognitive behavior therapy is the basic thing. It is given in the mood disorders. It is developed by R&D back, and usually 10 to 20 sessions are given. Each sessions last for around 45 minutes, and this therapy focuses on here and now problems, and the patient is taught to systematically evaluate their dysfunctional beliefs and negative automatic thoughts. They are also taught to identify and correct their cognitive errors, and to uncover and challenge their underlying depressogenic assumptions and beliefs. So then there is a behavioral activation treatment. So here what we do, the activity scheduling. So scheduling of daily activities and rating pleasure and mastery while engaging in them, exploring alternative behaviors to reach goals, and role playing to address specific deficits. So like it is there is a myth that psychologists they prescribe daily activities to patients. No, psychologists help the patient to make the daily activity routine, to schedule the daily activities. So it's psychology, they help them. They do not impose their own thing on the patient, like you have to get up in the morning at 5 o'clock. No. Let the patient ask at what time patient can get up. Okay, the day starts from there only. So there are different techniques can be used, like role playing. You can practice like that when you are showing the communication skills, time management, money management. So you can do all those things. The patients. Then there is an interpersonal family and marriage therapy. Interpersonal therapy is very important, where the depression was due to interpersonal issues, interpersonal problems. So you try to engage the patients in interaction with other persons, and there is a specific way to do this. Family therapy, you involve the family members also. Like if the child is having depression, so you call a whole family, you talk to the parents, siblings, and child simultaneously, and the focus is on the family system, like how the family work, how the family, the structure of the family, okay, the role of the different family members, the boundaries of the family members they follow. So the focus will be on those things. And in marriage therapy, like you call the partner, and then you try to discuss all those things related to mood. So focus on improving the interpersonal relationship of the patient so as to prevent relapse, educating people about their illnesses. About their illness is a common component of treating many disorders, including bipolar disorder and schizophrenia. So psychoeducation is also very important part of the treatment. In psychoeducation, there are so many components where we basically teach the patient, or we give the patient information about the illness, various symptoms, which may patient have, which patient may not be having, and the medication, treatment, psychotherapies, then the course, prevalence of the illness, and prognosis also. So we give all this information and we try to normalize the illness. Suppose the patient is having mood disorder, so we can say that the depression is prevalent in around 6% of the population. So professional helps the patient, the family learn about the symptoms of the disorder, expected time course of the symptoms, and the biological, psychological triggers for symptoms and treatment strategies, often combined with other forms of psychotherapy. Thank you. Namaskar.